Thank you. Good morning. And I hope I can borrow the 10 minutes from the previous speaker. I want to start by thanking the organizers, not just for inviting me here, but for putting violence against women on the plenary agenda of this important conference. 20 years ago, that would have been unthinkable because few senior public health officials recognized this as a health issue even. So in many ways, it is a story of success that we now have violence against women recognized as an urgent public health priority. And a lot of this progress is thanks to the tireless efforts of women's health and human rights organizations and advocates around the world that have persisted in their advocacy to put this issue on the agenda, together with sound public health efforts to garner the evidence that is necessary and has been compelling to make sure that it's unacceptable not to act. And I have to say that in spite of the progress, this has not been without some resistance, and this is by no means accepted in all places. Testimony to this progress are two recent developments in the global health, in the global context. Firstly, the Sustainable Development Goals. Their predecessors, the Millennium Development Goals, did not include any targets or indicators on violence against women, in spite of our advocacy efforts. And the reason we were given at the time was that there was not sufficient evidence. Fortunately, when countries met in September of 2015 to decide on the Sustainable Development Agenda, the goals did include this time a specific target on the elimination of all forms of violence against women and girls, as well as elimination of all harmful practices as part of the, within the Sustainable Development Goal 5 on gender equality and women's empowerment. And there are also some violence targets in SDG 16. The inclusion of these specific targets, of course, is an important recognition that these issues and addressing these issues are critical to achieving gender equality and women's empowerment, and that this in turn is central to achieving the Sustainable Development Agenda. And moreover, addressing violence against women is also critical to achieving some of the other SDGs, and particularly SDG 3 on health, and in turn addressing other SDGs that are related to reducing poverty, strengthening education, having sustainable, safe, and peaceful cities and communities that all contribute to the prevention of violence against women. The other political development, I would say, is the endorsement in the World Health Assembly of last year of a global plan of action to address interpersonal violence, in particular violence against women and girls, as part of the public health agenda. Again, not without a lot of lengthy discussions and negotiations and some challenges, but this was endorsed unanimously. And this plan of action identifies priorities. It proposes actions for member states, for other stakeholders, local and international, and for WHO itself, around these 4 strategic priorities. Strengthening the health system leadership and governance to address violence against women, strengthening health services delivery and health providers' capacity to respond appropriately, strengthening programming to prevent violence against women and girls, and strengthening the collection of information and evidence. And the plan is guided by commitment to human rights, to gender equality, and community participation, among others. So these two global frameworks and are important tools, and really give us a mandate that we haven't had before to move ahead in addressing violence against women. What has been the contribution of the public health approach to this? We started out following the Women's World Conference in 95, that had identified the lack of evidence, the lack of data as one of the obstacles to moving forward and to measuring progress, we set out to document the magnitude and nature of the violence that women experienced with a focus on partner violence, as well as its health and other consequences and risk and protective factors. And we started out with a study in 15 sites in 10 countries that were geographically and culturally diverse, where we used comparable methods that were developed in collaboration with both women's organizations and researchers and policymakers in those countries to be able to understand. We wanted to understand what is universal about this violence and what is context specific, and how can we develop information that will be used for developing policies and programs. And we then, a few years later, embarked on a series of systematic reviews to look at what data was available. And we came up in 2013, we published the first global and regional estimates of prevalence and health effects for two forms of violence against women, intimate partner violence and non-partner sexual violence. And I focus on those because they are the ones that are most widespread globally. They are also the ones for which we have most evidence, but of course there are many other forms of violence that women are exposed to throughout the life. And what we found was that the availability of data had increased substantially from when we started our planning for the multi-country study. At that time, there was very limited data available for low and middle income countries on this issue, but there still remain important regional gaps, and there are also challenges in the comparability of the data and in the ability of countries to produce this data on a regular way and to be able to produce trend data. Our estimates for partner violence were based on data from about 82 countries, and for non-partner sexual violence on data from 52 countries, so much more limited database. We're in the process of updating those, and already we see that there are many new countries that in the last 5 years have produced their first prevalence estimates. And these data have been shown already several times in this conference and have been talked about for the last few years, and I feel sometimes that they sort of have lost their impact, but I think that these are data that should make us all sit up, and it did lead our Director General at the World Health Organization, Dr. Chan, to call this a public health problem of epidemic proportions. We found that around 30% of women globally reported they had experienced either sexual or physical partner violence in their lifetime. This is women 15 and above. And if we included also non-partner sexual violence, that increased to 35%, so approximately 1 in 3 women. You see from this map that there are big regional variations. High-income countries, around 23% compared to Southeast Asia or Eastern Mediterranean regions, where we have rates in the near to or 37%. There are also large differences in rates of violence against women between and within country. And this is encouraging because in a way it speaks to these variations speaks to the fact that this is not inevitable and that we need to understand the drivers. And this is data from countries in the Asia-Pacific region. And in the larger circle, it shows the lifetime prevalence. And in the inner circle, it's the prevalence in the last 12 months, and I bring your attention to just how big the differences are between high-income countries like Japan and Australia, North America, where it is around 4 to 6%, the rates of intimate partner violence in the last 12 months, compared to some of the Pacific Islands or Timor-Leste, where it's in the 40s, or some of the countries like India and Bangladesh, where it's in the 20s. And 30s in other countries. And this speaks to both the drivers as well as to the ability of women to live abusive relationships, which varies very markedly between regions and countries. In addition to documenting the magnitude of the problem, we also documented the health consequences in this study where we did very in-depth systematic reviews, and there is research documenting the links between violence against women and many health outcomes, particularly sexual and reproductive health outcomes, chronic conditions, a big impact on women's mental health, injuries, as well as fatal consequences, including from murder, from suicide, and other HIV-related or maternal mortality-related deaths. And this graph shows some of the pathways through which these health consequences occur. A lot of the data is cross-sectional, so of course we cannot really say, but for the purposes of the estimates that we came up with in 2013, we based those only on longitudinal data, where we were able to say that the violence had preceded the outcome. And we found that women exposed to intimate partner violence were twice more likely to experience depression and almost twice more likely to have alcohol use disorders compared to women that had never experienced violence. They were 1.5 times more likely to have acquired a sexually transmitted infection, including in some regions HIV. 38% of all murders of women are perpetrated by intimate partners. And in relation to sexual and reproductive health outcomes, we saw that it's associated with higher levels of unwanted or unintended pregnancy, greater parity, first childbirth before age 17. It increases the odds of pregnancy loss, both through abortion and when it occurs during pregnancy, stillbirth, or miscarriages, increases the odds of low birth weight babies. So numerous health consequences that it has been important to document in order to really bring the attention of clinicians and primary healthcare providers to why this needs to be integrated into training of healthcare providers and into the work in programs that are addressing some of those consequences. In addition to the health consequences, of course, there's important intergenerational and socioeconomic consequences. If we look at the effects on children of women who experience abuse, it has been found to be associated with higher levels of infant mortality, and plenty of evidence suggesting that children who witness or are exposed to their mother's abuse are more likely to develop behavior and emotional disorders, more likely to have mental health disorders later in life, and importantly, there is a strong link with perpetration or experiencing of intimate partner violence in later life. It also has important cost implications in terms of the services that victims and survivors and their families use, health, legal, social, but also in terms of impact on productivity. So this data on prevalence and health consequences has been very important to putting the issue on the public health agenda and giving it visibility and raising awareness among policymakers, health policymakers, about why this is an issue they need to care about. In addition to understanding the magnitude and the consequences, we've also been looking at what are some of the drivers of this violence. And we now understand that violence is not the result of any one single cause, but is really the result of a wide range of factors that are interacting amongst themselves and across different levels of the socio-ecological model, from level at the individual level, where we have some things like the experience of childhood abuse or the witnessing of child abuse that is prominent across studies in different parts of the world, issues at the relationship level, at the community level, at the social level. And what I like about this graph, which comes from my colleague Mafulu in the Women's Equality Institute, is that it also encompasses the global. So there is a whole range of social norms that are being translated across all these levels of the socio-ecological model, and that impact across, and they're very much related to gender inequality and the acceptability of these forms of violence and some of the behaviors that individual men take on, also in their relationships and at the community level. So some of the drivers that have been identified through research around norms that justify or condone violence, and this is well documented in demographic and health surveys and the multiple the mix of the UNICEF that collect data on attitudes, and we find that there is a variation of the proportion of men and women who think violence against a partner is acceptable under different conditions, and that this is strongly associated with the prevalence both at an individual level and at a population level. Rigid gender roles and stereotyped constructions of masculinity, which translate into men's controlling behaviors and impact on decision making. And this is all reinforced by other social norms that reinforce violence in general and as part of masculine behaviors. Exposure to other forms of violence, I mentioned already child abuse, issues of substance abuse, particularly alcohol and mental health issues, and socio-economic and other forms of inequality and discrimination that all contribute to driving the prevalence of violence against women up. And this slide is interesting. It sort of illustrates some of what I said in the previous slide. It comes from a study that was done interviewing men, 10,000 men in 6 countries in Asia and the Pacific. And this provides shows the relative importance of the factors that came out in male perpetration of intimate partner violence. And you see some clusterings. In the green, you see a series of a set of factors that relate to the childhood experiences of abuse. And in the red, you see a set of factors that relate to these normative behaviors and attitudes that are commonly associated with predominant models of masculinity around number of lifetime partners, inequitable attitudes, controlling behaviors. And although alcohol is up on the right in another cluster, it also links very closely with those behaviors in the red. And the size of the circles is proportionate to the strength of the association. So important to address those gender inequality drivers. Based on this research on drivers and so-called risk and protective factors, there's been a growing number of programs and with different levels of evidence that have focused on addressing the 5 issues that are identified here. Firstly, transforming social norms around gender violence, and we have a number of promising interventions that have shown effectiveness in changing gender norms at the community level and at the individual level. Strategies to improve women's education and economic empowerment, strategies to reduce childhood exposure to violence in childhood, and a lot of efforts now being done around parenting programs, home visitation programs that have shown to be effective in reducing child maltreatment, strategies for improving partner or couple communication and learning non-violent ways of resolving conflict, strategies to address harmful alcohol use, and also legal and system interventions. And we have some examples of these. This is a summary of one of the systematic reviews, the most recent one that was done for a program funded by DFID, What Works to Prevent Violence Against Women and Girls, that is investing large amounts of money, around 25 million pounds, on research in primary prevention. This is the first time we've ever seen this kind of investment in this area. There are there's a lot of limitations to the existing database in terms of the methodologies, in terms of the length of follow-up periods, considering that some of the changes we are looking for are long-term. And there has been a tendency to focus on factors at the individual and the family level and not so much at the community and the structural level. And in a way, what we have at the moment is, randomized control trials on a few, single interventions. And what we really need is a package of interventions that are acting at multiple levels and addressing multiple factors, and that are being implemented in a coordinated manner in the way that we have tackled other public health issues, but we are not there yet, because only then are we going to really see a decrease in the prevalence at the population level. I'm just going to show one example because I don't have time, but this is an example of an intervention in South Africa called IMAGE, which was evaluated with a well-designed randomized control trial that looked at combining microcredit with a gender training intervention. And they were able to reduce the levels of intimate partner violence by half in a programmatic period, in 2-year period, as well as show other positive health benefits like higher uptake of HIV testing and reduced levels of unprotected sex. So we have a few examples like this that are at the moment in the field. This comes from Our Watch here in Victoria, which is an organization that is charged with developing a primary prevention framework and implementing it and it has identified actions around some of those key gender inequality drivers, and it'll be interesting to see, how a coordinated primary prevention approach is, the challenges of implementation, but also the impact. This is very much work in progress and in its early stages. What are some of the emerging challenges and opportunities? It's still a new field. We are still in early days. A lot of the current focus is on replicating existing programs like the one I showed, IMAGE, which is now being replicated in a couple of countries. There's a strong emphasis on RCTs, which of course we know are the gold standard, but there's a need to think also differently about different approaches to research and different stages of programs. Important to ensure that the prevention programs keep their political roots and involve local women's groups. For us in WHO, we have placed an emphasis, of course, on the role of the health sector in the context of a multi-sectoral response. We have done a lot of work around strengthening the healthcare response specifically, but we also emphasize that the role of the health sector cuts across all the levels of prevention, and that prevention is a continuum. So if we're able to work when we are identifying and providing a response to women, if we also start to address the needs of the children of those women, we will also have an impact on primary prevention. There's opportunities also in substance abuse programs to do more around prevention of violence. And we have highlighted some of this work in a series in The Lancet that was published in 2014. So if we look at the public health model, then we have done pretty well overall in defining the who, what, how, where, in identifying drivers. We are in the early stages of developing interventions, both for primary prevention and for the health sector response. And we obviously need still to do a lot more to identify what works for whom and where. And then the next frontier, of course, will be implementing effective policies and programs in a real-life setting and to scale. I want to finish with two things. One is the importance of balancing prevention and response. There tends to be this either-or mentality, and we've seen this pendulum swing in other things like HIV. We emphasize that it's not either-or, but it's both and that at the same time that we continue to focus on primary prevention, we need to strengthen the health services response and make sure that those service responses are implemented in a way that contributes also to prevention. In terms of the role of public health professionals, we have a central role to play in both prevention and response. We can collect and disseminate information on prevalence and drivers, and this is still needed in some countries. We can promote and conduct and evaluate research that improves our understanding of risk and protective factors and of effective and cost-effective interventions to address this. We can increase awareness and identification in services that already exist, particularly in services like HIV prevention, maternal and child health services, substance abuse services, measuring and disseminating information about the health and the social and wider economic costs, and promoting multi-agency partnerships. It's very clear that the health sector alone is not going to address this issue, but what I often hear from countries is that the health sector seems to be the last one to be dragged along. Kicking and screaming is the term that has been used. So we need to really and use this global plan of action that member states have approved in the World Health Assembly to really support countries in these efforts and advocate for policy and legal changes. So to conclude, we have made great progress in addressing violence against women, but we still have a long way to go. And Mary Burke, who is the director of our watch in Australia, was reflecting yesterday in our leadership dialogue on the profound changes that there have been over the past 30 years in population level attitudes towards smoking, towards drink and driving, and particularly in this country to sun exposure. And we expect no less for violence against women. And hopefully it will not take us another 20 years. We can and should be able to do this with concerted action, with sustained building of evidence, with persistent advocacy, and with partnerships across sectors and across society. We can make a life free of violence a reality for women all over the world. Thank you.